I am Addie Chappell. I'm the marketing manager for DataBank, but I have with me four excellent panelists who are going to be having a discussion today on this, and I will introduce our host, which is a healthcare practice director, Matt Murphy. So Matt, take it away.
Perfect. Thanks, Addie. Hello, everyone. Good morning. Great to be with you. Great to be joined by our panelists as well. I don't know about four great panelists, but I definitely have three other ones that can join and kind of talk through our whole talk track today, and certainly have a great one for you. Kind of providing a little bit of different aspects and lenses into kind of the pilot that we just got done doing, and kind of overarching content intelligence, which we'll talk to you and get deep into the weeds on from this webinar. But wanted to provide you all a little bit of a different lens, both from the clinician side, the HIM side, and then kind of from the technical side with Jim as well. So I'm Matt Murphy. I'm our healthcare practice director. I've been at DataBank for a little bit over 3 years. Prior to that, I was at Highland Software. So been in document management for about 10 years or so now, in all various verticals and things like that, but mainly within healthcare over the last few years. So excited to kind of talk to you a little bit about structuring the ambulatory side of data and making sure that that data gets put in the right place, the right time with the right providers to provide great patient care from that side of it too. So I'll go around robin a little bit and let our panelists introduce themselves, give a little bit of a background. Dr. Butler, I'll go to you first.
Yeah, thanks for having me. I'm Dave Butler. I'm a internal medicine and a pediatrician by training, med-peds they call it. I think it's at Baylor College of Medicine, born and raised Texas, small town, Texas A&M undergrad, UT Houston Medical School, and since coming out of residency at Baylor in 2003, joined Geisinger Health Systems, and they were one of the early adopters of the EHR, and that was my first foray into going from paper to pixels and all the complexities and intricacies that goes into it. So there I was their physician director of their first Epic optimization team. After that job, I was recruited down to Texas Children to help them implement over 47 practices from paper to the electronic health record from 2008 to 2011. Very successful, lots of really interesting workflows that you learn when you take a practice from paper to electronic health records, mainly how much we love paper. And I'll share some of those with you. Over those years, I've then since Bon Secours, Mercy, I was their associate chief medical information officer there. Then I got recruited to Sutter Health in 2014 as their vice president over all 25 hospitals in Northern California around their electronic health record optimization transformation. They had over almost $1 billion investment in Epic software over 10 years, and now it's time to maximize it. And that was my role there. Now I own my own consulting firm, Calyx Partners. We do a lot of physician coaching, vendor strategic advising, and physician training and workflow optimization. So glad to be here. I definitely have some experience in document management. Not by choice, though. There you go.
Perfect. Thank you, Dr. Butler. Jim?
Oh, I'm Jim Erb. I am the director of our professional services here at DataBank, but I've been in the industry, the content management industry, for the past 25 years, working on both the software delivery and implementation side, as well as our BPA centers, so our scanning and indexing. So I've done a lot in the OCR space, as well as regular indexing, and I've seen a lot of different scenarios in healthcare, as well as other verticals and government, et cetera. So I've had the opportunity to really boots on the ground, jump in and solve solutions as we move forward with our customers. So that's where I come from. My overall background, I live in the Northeast. I've been pretty much present in a lot of the healthcare systems up here in the Northeast, as well as the Mid-Atlantic region. And that's it. Joanne?
Thank you. Good morning, everyone. My name's Joanne Vaul, and I am by training and experience primarily working in healthcare, financial management, and systems. More recently in operations at a regional healthcare system as the Vice President of Physician Integration and Ambulatory Services. Throughout my career, I've spent a tremendous amount of time helping health systems evaluate decisions based on data and financial modeling. And that is really my role here today, is to try and offer feedback really from your perspective about what the possible implications of implementing this solution are. So we're really excited. I have about 40 years of experience in healthcare. I'm hesitant to say that. I think I might be the old guy on the call. But in a lot of different roles, working through implementations of EMRs, managing practices with many different specialties and many different locations, and watching, as Dr. Butler mentioned, watching my docs cling on to paper and hate the EMR. And a big part of the reason that they hate it is because there's so many different ways information can be provided to them, and they really get frustrated by the fact that it's not streamlined. So I'll be adding some perspective in that regard today.
Thank you all very much. Dr. Butler, I think we'll kind of just jump right in and maybe sort of tee things up from an industry perspective, and maybe from, you know, your clinical perspective as well, knowing that you've kind of worn a couple of different hats, both from the tech implementation side and from the clinical side and patient care as well. I guess if you can maybe start by telling us, you know, I guess, what is your current assessment of the healthcare landscape sort of post-pandemic? I guess, you know, we've heard the term COVID and you know, the post-pandemic, you know, I hate to use those buzzwords too much, but it's certainly something that we acknowledge, and there's a lot of different contributing factors. There's a few there on the screen that contribute to the current landscape. But from the clinician side of things, I guess, what is the current assessment right now in the industry?
Yeah, no, that's a solid question. I think those 4 bullet points you have there are probably the top areas of concern for the healthcare system that I've consulted with over the past year, 2 years, post-pandemic and pre-pandemic. Post-pandemic right now, you know, as like I said, the cards were all just shuffled up and thrown in the air during the pandemic. Where they're landing, it's an interesting place. You know, we have the new AIs out now, so on the tech side, there's some attention there. Maybe a little too much attention right now, where we need to focus a little bit more on the blocking and tackling still, but AI is very promising, especially as it relates to staffing. Staffing, I meant at least 4 large health systems in the past 6 months that I've consulted with have implemented at least 10% staffing cuts across. These are nurses, these are even some physician services that may not be available anymore to get their bottom lines back healthy. So those are things when health systems start cutting staffing like that, then we must look for other ways that we can still provide care for patients, that efficient care, I'll say, right? So so those are things that are top of mind, is staffing. How do you hire and how do you retain good staff? Nurses are really toasty, burned out from the pandemic, as well as docs. I mean, it was 2.5 years of, they just didn't know what to expect. And also, I think we saw that the healthcare systems had some cracks, whether it's through the PPE gear, whether it's how staffing is done, it's the overcrowding of the ERs and things, all the things that we saw during that time. And so now post-pandemic, they're exhausted, right? But now also there's a lot more tech that's being dumped on the US to say, hey, use this, use this, use this, or more digital, what do we call it, digital front doors and digital windows, and digital cracks are starting to open all around these healthcare systems and to get patients in access. But I think we got to make sure we have the right staff, the right people we're in place, right? And that all leads to the next one, which is burnout, not just physician burnout, but staff burnout. I think even executives burnout. There's a burnout epidemic right now, and physicians, and more importantly, are the ones that seem to have a higher suicide rate, 70%, you know, very high suicide rate. Very few folks understand that. And job satisfaction has gone down a lot of times due to the latest over the past 10 years, technology, moral injury, a lot of things that we call in the burnout spectrum, right? Lack of autonomy, lack of professionalism, things like that. So all those things are kind of right now plaguing the healthcare industry. So leveraging technology in smart ways that can somehow ease those burdens is going to probably be the move. So hope that triggers some questions. If you have any questions, and Addie, do they post them somewhere, or questions in the chat or something like that? Okay. And just do that. If you have any questions, then feel free. Matt, or Joanne chime in, Jim, on any of those if you feel.
Yeah, no, I think, it certainly goes, obviously we come at it from more of an operational type perspective where how do we support you as a healthcare provider from a partner perspective? Whether it's on the technology side, the paper conversion side, certainly on the tech side as well. From that side, I think you hit a good point there as far as just not just physician burnout, but an overall caregiving team burnout from that side of it as well. And sometimes that boils down to just what we're talking about today. And as far as document management, how do we make those burdens a little bit of getting information in, indexing it, getting it into the EMR and the repository side? How do we make that easy to take one of those burdens off if we're at all able to from that side of it? And that's really kind of the lens that we've taken over the last year as we've gone down this path of solving some of the ambulatory data and that side of it as well. So Jim, Joanne, I don't want to interrupt you if you had things to add.
I do have one comment, Matt. Staffing was the first item on the list. And I know from my experience, we had such a difficult time attracting, retaining staff throughout COVID and post-COVID for all the reasons that Dr. Butler mentioned. So the frustration of placing people into roles that don't really add significant value by doing something like manually moving documents from one place to the other place, that really is a huge motivator to our team right now to try and understand, how can we optimize people in a position so because we can't attract as many bodies as we really feel like we need. So that optimization of staffing becomes a real challenge.
Right. And one thing I'd like to add is on the technology, in the last 3-4 years, it really has stepped up its game with AI. Typically before it was just standard OCR products, which had been around for 20 years, doing the same thing, requiring a lot of programming and a lot of expense out of the gate to implement, where the AI has taken a lot of that upfront cost out and made it really easy to train this software and use this software, which makes the implementation a lot faster. And then what it can do in terms of replacing some of those manual steps, a lot of the manual steps, very quickly and efficiently is very impressive compared to some of the technology that we maybe even saw just prior to COVID.
Mm-hmm. That's a good point.
Jim, you teed that up perfectly for your section here as well. So knowing the 20 years of document management experience.
25,
okay.
But Joanne said 40, so I still feel like a kid. It's all good.
Own it, Jim. There you go.
There you go.
I said 10, so I'll take the kid hat on this one. That's
all right. So
I was just going to ask, knowing your experience in the field, I guess, how do you decide, I guess, within the projects, knowing that you've worn the SA hat and you're kind of the analyst side, but you also have seen the pilot that we're about to go into the results on and what's behind that. How do you, I guess, decide what to solve for within the medical records space, knowing, the DataBank side, but also on the provider side?
I think really the necessity of the documents, the volume. Labs are one of those things, and here's our sample where we've cleaned off all the PHI, and everyone's familiar with this view. Everyone's familiar with this document because there's so many, this overall volume. And then when you start to look at, the ability to classify and look at these documents, prior to the inception of really using the AI that we have today, what you had were OCR products that were all template based, and they would say that they weren't template based, but they were doing an OCR and they were leveraging a template or they were leveraging a lot of back-end programming. Now, what happens is some of this AI is smart right out of the box. I can put in 1,000 images, which is what I did for this pilot. And I ran through those images through the AI, and it actually grouped them in clusters. So what this allowed me to do is say, okay, here's 500 of the same document. And all I did was site verify a number of those documents, say, okay, yes, this is a lab. And then it found something from a different lab and it said, hey, this has a lot of the same information. Is this a lab as well? So it uses things like best guess. And when you start to apply that, and then you take the basic technologies, look for tag fields like date of birth, DOB, things of that nature, MRN, first name, last name, all of those manual steps where somebody would receive this on site, whether it be fax or email, they'd have to go through that process, do that patient lookup. They'd have to manually classify it, say this is a lab result, so on and so forth, all of those touch points. So there might be 3 or 4 people before this finally gets entered and assigned to the correct physician. So what we're doing is we're doing a data extract of that patient demographic information. And then we're also looking for the physician. So now I can take that, I can do a lookup against the database, which is what we did, find the patient, find their MRN, find the facility that they're associated to, and send it back. Also find the physician and then leverage that information to route it to that physician's inbox. So now when it comes back electronically, I've probably cut out on a per document basis anywhere between 10 minutes and 30 minutes of someone going through a manual process, or multiple people going through a manual process. And we walk through different organizations, because we've had this request not only from the pilot program, but from other health systems, where we go in, we look at it, and everyone knows those faxes just come in and they just clog a queue, and they're there to work and work and work. So whether they're coming in from fax to mail or fax to a share, somebody still has to have multiple touch points before it's actually in your EMR. Any questions?
I guess knowing that, I guess maybe Jim, if you could kind of just give us a 30,000-foot view of, you know, the pilot that we just completed. I guess I'll get into the technology side, you know, here, and what sort of encompasses that from our side, just from an overarching standpoint. But I guess if you can get into maybe just a little bit of what the scope of that pilot was with the 2 different practice areas, and I guess how that went for the major Mid-Atlantic healthcare system that we did the pilot with.
So for the pilot program, we had 2 departments. We had radial oncology, and we had one portion of a transplant department. And the way they sent those files to us, they came over in 2 different ways. The transplant sent us documents that they had pre-screened. They looked at them, do I need them today, or can I just send them to DataBank to index? The other department said, here's my right fax that's incoming, route it to a queue, DataBank will pick it up via SFTP. So everything that was sent over from these 2 different practices were treated pretty much the same. We fed them through our AI engine that we use in-house. We leverage our SQL data that we receive from this customer on a daily basis. And we really begin to put the 2 together. So we were able to use the AI to do the correct extraction, and then use the tools that we have in-house to match the data to the database, so that we could turn this around in a relatively quick fashion. So what we're able to do is take that document that may have taken, you know, all morning for somebody to do, turn it around in, you know, less than 30 minutes, repost it, and have it ingested into the EMR. What was nice about this is all the data we extracted also send over the correct HL7 messages. So it was available in the EMR, as well as the content management system that was associated to the EMR. So now we're able to go in, click on the image, see it, and then do any additional entry. So in this case, this was our phase 1 pass, where we did not do any of the extraction of the lab results. But that is actually a phase 2 project that we are looking at. And the AI engine that we use has that type of ability, where now I can go in, do the lab extraction, take a look at those results, and compare them to a data set for the compendium to make sure that things are in range, mark out those correct flags, etc., and then send that over in a result message. So there's a number of different things that we can do. What's nice is the efficiency is that I've only need to set this up one time, and then I was able to ingest the second department. Any of the exceptions that I had, I was able to train those exceptions and then apply all of that same technology. So if I started with one department, I can now literally cookie cutter. And a lot of times people use that phrase and it's a vanilla, right? It's a vanilla install. This, you really can leverage the existing base of documents that you have in that catalog, because really it's doing a catalog comparison. And when it does that, it can classify the documents a lot faster. So every department that you implement isn't a start at ground zero. You're already piggybacking onto the work that's been done in the previous install.
Hey, Jim, let me ask I just want to ask a tag on that one. Not ask, I think I know, but it's a personal thing, right? So my brother's at the VA, heart failure. He told me I could say it, whatever. But he's had all these labs done over at Baylor, Scott and White, and now he's going to go to the VA. There's lots of records there, right? And I don't think this one particular VA is, well, I met with my friend that was there. He said he usually requests records to be faxed to him. You know, he's like the health tech person that gets the records. And then once they fax it to him, he then puts it into the VA's EHR. And now what I think I just heard, because he's had a lot of records, right? What I just heard you say was it's almost possible, it will be possible soon that if they're scanned in, it can scrub off those discrete values and place them with wherever the other lab values live in that EHR, so that as a doctor, when I click on the BNP, which is a sign of heart failure, is it getting worse or whatnot, it will trend along the same lines as if it's interface labs. Is that kind of where we're going on that one?
That's exactly where we're going with that
Wow,
one. So
that's
the
nice.
ability
Okay.
to just scrape the lab data and mark it as a lab is fairly simple. And that was the initial goal. How can we feed this? You know, is it going to classify? What level of dropout are we going to have and what level of exception? But to take it to the next step and the next level is really to do that lab extraction, match that up to the compendium, and be able to say, okay, not only did I bring your lab to you, but here's the results that you now can look at and you don't have to key. So there's an additional savings. Once again, that was the phase 2 approach for this pilot. Then we're still evaluating for the phase 1, but the overall results that we had were very impressive in terms of exceptions. And do we have a slide on that one, Matt, or should I let that? I don't want to let the cat out of the bag.
No, I think.
Okay,
We'll get into some of the
had
results with Joanne here in a second.
Right. So when it came to the radial oncology, where everything was sent to us, we received, and everyone on this call has probably received it, everything from menus to roofing contractors to VNA. You name it, it came in on top of the medical record documents. And we were able to screen those out, take the things out that didn't need to be sent over, and then just send over the important documents. Flag off any exception documents maybe we didn't match to the correct patient, or we didn't have that patient information. But when we want to talk about things like, especially in transplant, where I get my prior records, I get my entire medical history, send that over. I can break those documents out into the individual. So if I receive a 30-page or 40-page packet, I can now slice and dice by each of the different classified documents and assign them all to that same patient. So now it's available as you would expect in your typical folder view. In the other department, which was the transplant, where we received everything that after it had been pre-screened, we had 0 classification errors. So everything they sent over, we were able to identify right out of the gate. And then we only had about 14% of exceptions. And those were typically where the information didn't make it to our database yet, or the patient hadn't been registered. So we were in pretty good shape there as well. If you think about only 14% of the documents coming in having to look at, it's actually pretty good.
Fantastic. So I'll kind of cover off from the technology side of just a very high level. So you've heard Jim kind of mention a little bit about the AI engine we've used behind this ambulatory records pilot. You know, and I think there's a couple of different components in there, which I think this graphic highlights really well, is the fact that we're able to first take that ingestion standpoint, and our ingestion is very, very flexible, and we'll get into that on the next slide a little bit, as far as we don't have one rigid way where we have to take in the documents. That can be flexible and pretty agnostic from that side, based on each healthcare system's requirements from that side. So we take the artificial intelligence engine and we run the images through that side of it. But I think to go a step further with it, we use the machine learning aspect of it to make sure that if it doesn't necessarily pick up on something in the first wave, that is easily able to be cascaded down in a correction that will, of course, kind of pause everything, go through and make sure that it learns on future documents, which could be in that same or the next batch too. It's not necessarily something that we have to stop everything on, reprogram it, and that's the way that it learns. It is very much machine learning from that aspect in every definition of that. So it's self-learning. We can actually teach it, and we can do that in a one-click kind of cascading fashion as well. Now, if one of the scenarios that Jim highlighted, where let's say we get a pizza menu in, and that's input through the patient records, obviously that needs to be flagged, and the intelligence and the machine learning will kick that out into, kind of an exceptions queue at the very end of it, where we have folks on the DataBank side that will go through that work within HIM related documents all day, every day, for different healthcare systems. So they know exactly what they're looking for, where to classify that, and specific to that healthcare system too. They'll be able to go through, say, okay, well, this is obviously not something that needs to be tied to Jim Erb's patient record, and go through it from that way. Or if it is a document that does need to be classified, and maybe the image that we got was skewed, maybe things were covered up, but we're able to go through within the EMR, within the repository, do a patient lookup and get that record where it needs to be, but only handling that exceptions aspect. And I think, upwards of 90% is very, very typical. And this was a very small set as well, meaning the more documents you have, the better the intelligence is on the back end of that too. And this sort of covers through a little bit of our workflow when we look at content intelligence, which is absolutely our name for this solution and this pilot that we just finished up as well. So we really first do a full evaluation. So Jim and his team will go in with that healthcare system, go through, find all the different intricacies, within the ambulatory side of how we need to ingest it. Where does the output need to go to? And we sort of back into everything in the middle, kind of from that way as well. So it's really being flexible and agnostic as far as both our input and the ingestion methods, but as well as the output, and really letting the middle part kind of be the actual intelligence from that side of it as well. Certainly we can handle the ingestion, the output, and the exceptions, and really the software and the intelligence does the heavy lifting on that side too. So Jim, anything you wanted to add on this one by chance?
I think really to set your goal is probably the most important one here, because all of the rest is really just a fact-finding mission.
Right.
If you set your goal so that it's attainable, then I think you have an overall higher rate of success in terms of implementing and rolling it out across the organization. Because if you go with that phased approach, maybe we're going to bring on 3 at a time, 3 at a time, 3 at a time, you have a lot more control on the process.
Sure. And Dr. Butler, I'm curious from your side, the actual success criteria. You've been through a lot of tech implementations from the CMIO side of it. Where have you experienced both sides of making sure that you define success criteria for these projects, and I guess how does that necessarily translate from the physician side and the healthcare system side of it as well? I mean, we certainly define the success criteria, put that in writing within this pilot as well, and happily we checked all the boxes off. But just curious if you've been through those sort of goal setting exercises on your side. Oh, you're on mute.
Absolutely. As part of just large go lives implementation, especially when we're the beginning of an implementation, a lot of folks understand this, to take a practice or a hospital from a paper-based system, which not a lot of doing that now. They're going from EHR to EHR, but to do that, it takes a lot of planning, a lot of KPIs to say, okay, how do we know that this is successful? First of all, what we had to do is really let the doctors know and folks know, like, you can't have everything. Okay, we're not gonna just scan, we're not gonna reproduce a paper chart in Epic right now by scanning all the stuff you think you may need on a patient from 50 years ago, right? And so that was always one of those things we had to create governance around. What is our document management strategy? What should be scanned? What should be shredded? What should be go off the Iron Mountain, never to hear from again, right? And so those are very difficult to do because, as you know, all these things have a cost. So there's KPIs as far as like the type of documents that's going to be scanned, what percent of those. And also we even have been innovative where we used document management like this to even help train the physicians, where before they go live, negative 2 or 3 weeks before go live, we'll have them pick their patients that they're familiar with, use the chart, go through the paper chart to do this, this, and that. Then we put it in a bin to say, have them scan it, shred it, or do something with it so that they have the source of truth, in a paper form right there in Epic. For example, if on the problem list, we have heart failure and this patients have been physician's patients for say 15 years. Well, the last thing you want to do is go live with an EHR and the only thing you have is a couple of data points electronically here. So going to that nicely indexed place, I call media managers, usually what we call it, where we can find the last visits that we chose to scan in, or the last EKGs. For example, we will never scan in more than 2 EKGs. MRIs, get the MRI. Like any big studies that we have a whole process to know what is the clinically relevant things that you want when the patient first shows up, so that we're back on. We feel the patient feel like we're all over it, and that's what these sort of systems help us do. Document management. It's just a history. A patient may say, "Yeah, I think I was admitted one time in this clinic or whatever," and that when they say that, we panic a little bit because we're looking at Epic. We see nothing. But we're like, oh yeah, media manager. You can go over there and then you can kind of see a little bit more of that paper record and just make the patient feel like we know what we're doing, and that's what patients want, trust, right? And so, so those have been my experiences for us. How I have made sure that we implement these sort of systems is to make sure it's physician focused, but also patient friendly, and now with some of the newer technology, we're able to even allow some of these documents to be shown to those patients via MyChart. I mean, typically those are like all reserved, stuck inside of Epic, but now my chart, they can click and see some of the scan documents. So all these are attempts to get the patient back their data. It's not our data, it's their data. So yeah, I hope that answers your question, Matt.
Yeah, it absolutely did. Thank you. And Joanne, I'm going to kind of turn it over for you a little bit, but before you kind of dive into some of the results from this pilot, I guess, can you tell us a little bit about your role within the pilot and sort of, finding and reporting the results from throughout it as well?
Certainly. Thank you, Matt. Yes, my role was to function in an independent manner through this process. I was not part of the pilot. I'm not part of DataBank. It was proof of concept work that they asked me to do here to help the client present information about the projected ROI on the project and about how that was determined. So my background in finance certainly came in handy. My background in operations came in handy. We went down to the client and met with many people from their operations team, asked a lot of questions about how and why they were currently functioning, and why they were doing things the way they were doing it. And then did a comparison of the current operations plan to the projected with using the results of the pilot. So it was a great experience. And again, to all the operations people on the line, we all struggle with the same things. We get documents and information from so many different sources, from the patients themselves, if it's a new patient, in a department like the transplant department, from all over the world. Information is coming in all different directions, and we may get it and receive it as an image, which is a way step better than when we used to receive it all as faxes, right? But now we get it as paper faxes, that is, now we get it as an image, but somebody was still touching every single one of those documents. And that's what will change with this particular product. So the first question we asked them is, how many FTEs do you currently have handling documents? That ranged from 0.6 FTEs in one department to 1.25 FTEs in another department. I know from our operations team, we really had it spread out throughout the practice. When we started, we centralized a lot of the indexing work because it just didn't get done. I happened to be in the office the other day and saw a message in Teams that said the following people have more than 100 documents in their inboxes, that need to be indexed to the appropriate chart. And it was not a short list. So we know that it's not a simple, there's Joanne and she does this work all day, every day, but it's really in a lot of cases a fragmented process. But fortunately, the client was able to answer the question and gave us those estimates. We multiplied very simply those hours times an hourly rate. Again, This is input that all the clients would use their own data for. We didn't include fringes. That was a lot of debate about that, and we can certainly answer questions in that regard, but we didn't do that. I can assure you that that significantly increases the ROI that I calculated. We did it both ways. We estimated the cost for handling the documents as between $26,000 for Department 2 and $44,000 for Department 1. The number of documents that were being handled annually were 19,000 for Department 2 and 27,000 for Department 1. That's a really important number when you go to quantify the potential value of a product like this. You're going to have to know what the volume of work that's being done really is, and the number of staff hours that are being burnt to do this work. So the current cost per document for this pilot client ranged from $1.35 to $1.64 per document with the existing workflow.
And before I jump to the next slide, Joanne, I just wanted to call out for all the attendees. So the enterprise-wide scope, if we handle through all the different departments, right, is 9 million documents on average too. So I just wanted to kind of quantify that, you know, these are two small areas within sort of the overall enterprise-wide view, and we can actually see, you know, why they're looking at it from an overall cost perspective by each department, but collectively too.
And I think that the fact that we did two departments within the health system, the volumes of documents in those two departments was relatively low compared to the ambulatory practice as a whole. When you look at a physician practice in any specialty, the volume of documents coming in, it's not as sophisticated as everything is in one place. Everything is in Epic, for example. In a lot of health systems, it's much more fragmented than that, which just drives the cost up. So at the top of the second page, we see here the DataBank fees per document. That is a combination of implementation fees and per image fees. And it came up to 57 cents for Department 1 and 43 cents for Department 2. So the projected cost is more than just the DataBank cost, right? Because they're doing a lot of work that will still continue. So a small portion of it will still continue for those documents that Jim referenced before that don't get matched on the normal workflow through the DataBank process. There is always going to be some level of manual intervention, whether it's done by the client or by DataBank or some combination of the two. So we considered that as we did this quantification and basically came up with a projected cost per document post-implementation of this service of 70 cents to 81 cents per document. And I know as a finance person in healthcare, we typically don't think of things on a per click basis. We usually think of things on a department-wide basis, but we were really trying to drill into the marginal value of the service per document. So we ended up with savings per document of 83 cents in Department 1, 65 cents in Department 2, which gave us a return on those DataBank fees above of approximately 150%. So that's an outstanding ROI with projected savings of $22,000 for Department 1 and $12,500 for Department 2. The last slide here in terms of the financial model extrapolates what you just heard to the whole health system. And as Matt mentioned, there's over 9 million documents annually within this health system. Current cost per document is about $1.56. The projected cost at 69 cents and the saving per document of 87 cents. So we're really cutting the cost to something less than half of the current cost for handling these documents, and a projected ROI on the DataBank fees for a health system is going to be higher because the implementation fees go down. on a per document basis. The projected savings for this health system was in excess of $7.9 million. So there's a lot of numbers here, but the basic message is pretty straightforward. If you quantify the amount of hours and costs incurred in doing things manually and focus on how could we better use those resources, we're going to save money. If we cut the costs, we would absolutely save money, right? The annual savings of almost $8 million in this really large health system. However, there is opportunity cost too. As we talked about earlier, the fact that I couldn't attract staff to do the things that I thought were important, and instead I had to place staff in doing manually indexing documents and images, was a point of frustration to me, and I got to believe the point of frustration to a lot of people on this call. There are so many things that could be a better use of those same resources. Things like improving patient satisfaction by being more responsive to the patients, getting one extra patient into the schedule a day because the nurse pracs that are receiving the documents at the last minute or realizing at the last minute that they didn't receive an important piece of information and having to cancel or delay a patient appointment. These are real valuable potential improvements in the workflow in the health systems. And when you talk about the downstream revenue associated with those opportunities, the numbers get even more dramatic. So there's the potential cost savings. It's real. There's no doubt that this automation process, just like automation processes throughout the world right now that we're hearing about, can significantly reduce the man hours spent doing this work. But from an operations standpoint, when I look at it, I look at what could I do with that same resource that would add a significantly increase the value of that resource. And that would be the debate that might occur within your health system about whether you really are going to realize these savings, or are these savings going to be a demonstration of how that resource might be better utilized. So I think the results of the pilot were outstanding, and I think it was a great experience to work on the project.
I agree. Certainly I'm from the peanut gallery. You and Jim were certainly, kind of the backbone of this. And I really appreciated, Joanne, the kind of the independent view, non-biased, making sure that the healthcare system has a true analysis of how this pilot went, with a complete unbiased opinion like that too. And I think what stood out to me is the fact that the annual savings of 7.9, that's without the fringe benefits. So that is extremely conservative, to a very real factor, from that side of it as well. So that was very, very surprising to me too.
Yeah,
so.
on that one too, just to add a fine point on that one, I think what is probably easily missed when it comes to ROI, technology, healthcare, which I absolutely hate the terms ROI and tech and healthcare, because it's hard to really quantify some of the wins, especially with all the downstream wins, such as physician time spent looking for documents, right? Errors clicking on something you thought was a pap smear, but it's an EKG because it's misindexed, so those are things that are really hard to quantify, but occur a lot. So just want to add that there. Those are the non-tangibles probably. So just want to add that from a clinical perspective.
No, absolutely. I think you can see some of the results both from the lab side and from the record extraction side of how content intelligence, we talk a lot about this, and it's hard to necessarily, I'm a visual person, so this to me actually shows, what we're grabbing. Certainly we can meet with anyone and kind of show them a little bit under the hood, of what this actually can extrapolate and grab off of that without anyone ever needing to touch that as well too. So with that being said, Addie, welcome back. Good to see you. I know we have a couple of questions, so I'll let you kind of moderate and let us know how we want to address those.
Yeah, absolutely. And anybody who has any further questions, feel free to use the Q&A feature. But the first question we have, I think, is for Jim and Matt, and even Joanne, if you want to chime in. What kind of unexpected issues did you guys run in run into with this pilot project?
None at all. No, I'm just kidding. I'll let Jim chime in from that side, and then Joanne, if you want to add.
I think some of the problems we ran into were related to some of the data extracts and marrying the correct data to the right record out of the gate. But other than that, everything was relatively smooth. Few small issues that we ironed out in the very first day. So after day 2, we're pretty much up and running and in good shape.
Joanne,
Well, that's great to hear.
any issues you saw? Oh, sorry, I was just
No,
going
you're good.
to ask Joanne, any issues you ran into from your side?
No, I mean, with respect to the project, I really wasn't involved in the project per se. With respect to, really quantifying the potential impact, I think it was just eye-opening to the people that were involved, how much time was really being spent and how high the match rates were. Sorry, that's not a technical term, Jim, but how successful the project was. I think trying to make sure everybody really grasped that that was probably the biggest challenge.
Right, and I think one of the observations that came was the consistency in practice across that department, where user 1 may have handled a document a certain way and then user 2 may have handled it a different way. Those were more the items that we came across. So typical things that you would find in any new software implementation, some of those teething things started to come out.
That's great to hear. I think kind of a follow-up question we have for this, and this is going to be more for you, Joanne, is why these ROI numbers? What made them important in the space of this pilot specifically?
I mean, if I understand the question, the ROI in this case was relatively straightforward. I mean, I kept saying that to the DataBank team. This is pretty clean. We're going to save man time. We're going to improve accuracy. We didn't put any value into the accuracy improvements. There were a lot of things that we could have included in those ROI numbers that I know what it's like to sit on the client side of the discussion and know what is defensible when I go and talk to the CEO and the CFO and the CIO about wanting to implement a project like this. So we really tried to make it straightforward and say, we're going to save this amount of time and we're going to see this benefit. So I'm not sure I answered the question, but it was a relatively straightforward time savings.
Awesome. Dr. Butler, I think this one's for you. How do you think the future of healthcare changes with AI?
Not at all. It's going to keep, no, that's a joke. Wow, this has probably been the past 6 to 8 months I've been digging deep into some of the GPT 3.5 and some of the large language models and all the other fancy words that are dropping around, AI. And so I can say this, and I'm working with some software, large vendors and some third-party vendors, it's going to change significantly. I mean, you all have actually been the AI, machine learning, you've been doing it. Before it was cool, probably just didn't know that's what it was called. Now with the generative piece, I think it's going to add a lot more oomph to healthcare in general. Mainly, I look forward to some of the things that some of the large EHR vendors such as Epic is doing with it, where patient message, you email your doctor, it's going to go through the EHR a little bit and help prep the physician to answer your question more intelligibly, where they don't have to search and find data, it'll pull the data. So imagine a world when all of these documents that are getting scanned in are OCR, indexed, the words are there, the language is there, and now we're able to grab any of that data, say, hey, when was this patient's what was the last 3 results of their pap smears? Because we may only have 1 in our system, digital, the other 4 may be scanned in from some outside source. Now it's going to be able to grab that and present it evenly, and we can see trends and be able to predict whether future cancers or things like that will come up. Also, just from a patient perspective, it's like the access part to getting into healthcare. When patients apps are going to get smarter, better, more empathetic. Studies are coming out. UC San Diego. Right now, I'm at a conference in Ojai, California, AMDIS, and we just had a big discussion yesterday on AI, generative AI. What does it mean? Radiology, imaging, can it be used to help streamline some of those costs or make more accurate diagnosis at lower cost? So all these are coming up. It's going to be disruptive, but I think it's going to be really cool. And I heard someone say, it's probably the most terrifying but coolest thing that we have seen hit the world. And but for healthcare in particular, I think it has more upside than downside right now, especially as a lot more of the vendors and the government and some of the hospital systems are looking at putting guardrails around some of those things to mitigate some of the negative, or I call the side effects of AI, and so that we can focus on the effects. So that's my predictions, and there you go.
Thank you. Matt, do we have any final thoughts? And then we'll go ahead and wrap up.
Joanne used to say we have to, it's like putting a quarter in the swear jar when you forget to hit mute. So I'm still.
Except it was $100, Matt, to your favorite charity.
All right,
don't minimize that.
Yeah, all right. We'll pick a favorite charity and do that. But Dr. Butler's in it for two, just so.
Oh yeah, I'll go broke. I'll go broke doing this because I'm terrible at that mute button.
To answer your question, Addie, I don't have too much. I mean, I think to wrap up on, we've done a couple of speaking sessions at some local HEMAs on more centered around the East Coast, and that presentation we can make available to everyone as well. And it really talks about kind of the operational side from our side, right? How we can't really throw bodies at larger indexing projects or daily indexing projects like we used to. So we've really had to evolve, but we are a more tech forward company anyways, from that regard. So I think, this really couldn't be more perfect from a timing perspective to align with our company, how we've evolved, but also making sure that we support our partners. And by partners, I mean our providers that are out there on the front lines every single day. If we can make their jobs a little bit easier, I think we've done it from that side of it as well. And I think the results show it. So from that side, I think I'm good. I think we've answered pretty much all of the questions, but I know there's one more piece here, Addie, if you want me to talk about that, if you want to.
Oh, no, I'm good to talk about it. You guys welcome to scan the QR code if you'd like to learn more about what Content Intelligence offers. We are about to launch an ROI calculator. So you guys are going to get more email communications tomorrow about an ROI calculator where you can actually plug in your own numbers and look at some of the results that could be estimated for your particular department or practice that you're using. Obviously, it's estimated saving, but it is something that you guys will be able to interact with and use your own numbers for, and we'll be sending email comms about that. But other than that, thank you, Joanne. Thank you, Dr. Butler. Thank you, Jim. Thank you, Matt. Really appreciate your time, and thank you, everybody, for joining us. I hope you guys have a great rest of your day.
Thank you.